remember, and this is quite the same in adult neurology and child neurology, how to make the correct diagnosis of epilepsy, how we manage childhood epilepsies, but then we're going to discuss a little bit more about some challenges that we have to face as pediatric neurologists. And one of those challenges are the devastating developmental and epileptic encephalopathies, with a glimpse of hope there, because there are some new advances with precision therapy, targeted therapies in some of these. And then we're going to end up with a very interesting part as well that relates to the encephalopathy characterized by continuous spike and waves during sleep, which is something that we also mostly see as child neurologists. And we're going to think a little bit about what is the impact of the interictal discharges on cognition and behavior. So let's start off with an introduction and some basic concepts. We all know what an epileptic seizure is. An epileptic seizure is a transient occurrence of signs or symptoms that are due to the abnormal, excessive, or synchronous neuronal activity in the brain, a disturbance in the firing, in the electrical activity of the brain. And epileptic seizure might look exactly as a non-epileptic event, and this is what is troublesome sometimes to make the correct diagnosis. In fact, the manifestation of an epileptic seizure can look identical to a non-epileptic event, and these non-epileptic events, as we can see, can be a consequence of either a brain disturbance or of a disturbance of the heart or any other organ. So we know that the basic division is between generalized epileptic seizures and focal epileptic seizures. The terms have been reconceptualized. So just to remind quickly that we don't expect the whole brain, every part of the brain to be affected to call a seizure a generalized epileptic seizure, but we expect that networks hemispheres to be affected. So a generalized seizure may start at some point within some network, but then it rapidly engages distributed networks, and that's what makes it a generalized seizure. And most seizures we are aware of are the generalized tonic-clonic seizures, tonic myoclonic seizures, atonic and absent seizures. I will go quickly through these section. And the focal epileptic seizures are originated within networks limited in one hemisphere. And here we have a classification as well, but this is based on semiology. We have motor or non-motor focal seizures. We have focal seizures with just autonomic features, or just behavioral, or even cognitive, or even emotional. And we have focal seizures, which is an important distinction to make, with retained awareness or impaired awareness, previously termed simple or complex partial seizures. These are all terms that have now been outdated. And of course, according to exactly the topography of the electrical activity that generates the seizure, we have frontal lobe seizures, temporal lobe seizures, parietal, occipital, and so on. And this is just a reminder of the classification seizure types, the most recent one that was published in 2017 in Epilepsy. And a specific seizure type that we mostly see as pediatric neurologists is epileptic spasms, which is a distinct seizure type. And we have epileptic spasms of focal origin, classified as focal onset, generalized onset, and also of unknown onset. So epileptic seizures we have covered. What is epilepsy? We all know that epilepsy are merely symptoms, they are not diseases, and we can have epileptic seizures that arise in the context of a temporal reversible disorder, and these are called acute symptomatic seizures. And when we think about epilepsy, this is something different. When we think of epilepsy, then we think of disorders that the brain has this predisposition to generate spontaneous seizures. And it is also very, very widely distributed in forms of etiology and phenomenology. So it's not practical to refer to epilepsy as a disease, but we have to think of epilepsies in general. So in 2005, the International League Against Epilepsy gave this definition as a disorder of the brain which is characterized by this predisposition to generate seizures, but also added the neurobiological, cognitive, psychological, and social consequences of this condition. And this makes us think of epilepsies in a broader way. And the definition then required the occurrence of at least one seizure. And this has been updated in 2014 with this operational definition and explains how we can make the diagnosis of epilepsy even after one epileptic seizure. And this is why, because epilepsy is a disease of the brain, which can be defined either as the occurrence of at least two unprovoked or reflex seizures 24 hours apart, or when we have a background abnormality that makes us think that after one unprovoked seizure, the probability of further seizures is similar to the recurrence risk after two seizures. And of course, we can make the diagnosis of epilepsy when we also can define a specific distinct epileptic syndrome, even from the occurrence of the first epileptic seizure. Now, the important thing to bear in mind is that epilepsy involves recurrent epileptic seizures most, but that doesn't mean in children that this is necessarily lifelong. So many children, actually most children and young people, will have seizures and active epilepsy just for a matter of months or years. They might be on anti-epileptic medication for a few years, and then this epilepsy might self-limit itself. So this is a very useful way of thinking of epilepsy. So we need to start from the seizure types. This is a proposed algorithm for classification of epilepsy by the ELE. We have to start from seizure type and then try to classify the seizure types in one of these classifications that we mentioned before, and then see if the characteristics of this person's epilepsy can make us diagnose an epilepsy syndrome. And at the same time, whether we can diagnose an epilepsy syndrome or not, think about the etiology of the epilepsy. And this is a list of the now proposed etiologies. We know of the previous classification of etiology as idiopathic, cryptogenic, or symptomatic, but this has now been replaced by more specific etiologies of epilepsy, which is genetic, structural, metabolic, immune, infectious, and unknown, and at the same time integrated in this comorbidities, which is an important part that it has been touched upon by the previous classification. Now, just to remind everybody and what an epilepsy syndrome is, this is a distinct epilepsy condition, which is characterized by certain signs and symptoms that define it as unique, but these are mostly the age of seizure onset, the history of seizure types, the neurologic examination, and the EEG features. It doesn't have to do with the etiology. So epilepsy syndromes can have different etiologies. So we can define West syndrome or Lennox-Gastaut syndrome, but they can have different etiologies. And this is just a list of all the syndromes organized by age, and also other conditions or epilepsy conditions that are not defined as syndromes, which are actually very common, like the epilepsy, which is secondary to this is a condition, an epilepsy condition itself. It is not a syndrome. And also, I urge you to see a lot more about this classification of syndromes, and also see a lot of videos with seizure types in the epilepsydiagnosis.org site of the ELA. And finally, talking about etiology, I'll just have to remind you that this is something that we think early on from the first seizure, and it is very important sometimes when we think about treating people who have epilepsy. We give a specific to recognizing treatable etiologies, and which is the case for some metabolic epilepsies or some structural epilepsies. So we also need to bear that in mind all the time. And these are not categories that can be specific for a person. Some people can have both genetic and structural, as in tuberous sclerosis. And of course, with the metabolic diseases, these are also mostly genetic. So the one does not exclude the other as an etiology. And of course, the big breakthrough the last decades has been the identification of the genetic etiology in epilepsy. It started off with familial cases, and it started off with a recognition of the channelopathies, but now it has there is increase in the knowledge of underlying monogenic etiologies, mostly in the severe encephalopathies, epileptic encephalopathies. Now have the ability to perform next generation sequencing, which has been the main huge change in our everyday practice. And this has also been the stepping stone to finding therapies, targeted therapies for some of these epilepsies that can help change the course, the initial course, and prevent the devastating effect of some of these epilepsies. We will see a little bit more about this coming to the next part of our presentation. The last thing I want to remind everybody when we think about epilepsy, and this is especially true for pediatric epilepsy, is comorbidities. Sometimes, or I may say most of the times, epilepsies are easy to treat. In a way, the drug-resistant epilepsies are the minority, of course, an important minority, but our everyday practice has to deal with the comorbidities of epilepsy in children. And these range from sleep problems or behavioral problems to comorbidities that are intellectual disability, problems at school with their academic abilities, and we see comorbidities with some of the neurodevelopmental disorders such as ADHD and autism in childhood epilepsy. But of course, when we have to deal with epileptic encephalopathies, then we do have other comorbidities with cerebral palsy or movement disorders and problems with nutrition. it is important to think of the epilepsy as a whole and not just seizures. So let's try to see a quick overview of the childhood epilepsies, starting with the epidemiology, trying to see how common are epilepsies in childhood. And actually, seizure disorders are common in childhood. Up to 10% of children will have a seizure, and pediatricians are quite familiar with dealing with children who have seizures, such as febrile seizures, for instance. But only a few children will be diagnosed with epilepsy compared to this big percentage. But of course, this percentage is higher than in other age groups. We know the curve that has a peak in age and then early infancy and early childhood. It plateaus around age and then it starts to rise again in the older age group, and especially in children who are less than 3 years, we have more commonly recognized seizures and epilepsies, and these are unfortunately associated with a higher prevalence of drug resistance, a developmental comorbidity. So overall, the prevalence of epilepsy in childhood, 5 cases per 1,000 children. So we have a school, a big high school with 1,000 kids, so 4 or 5 of them is common. Now, when we go to neonates, what is the etiology and frequency of seizures in neonates, we will see that more than 1/3 of cases here are secondary to hypoxic or ischemic brain injury. So we have mostly symptomatic, as we would call them, seizures in the neonates, and the higher percentage of them have is due to hypoxia and also hemorrhage due to prematurity or some infection, and a smaller percentage is due to brain malformations. And the amount of neonates that can be diagnosed with a genetic epilepsy is much lower. But this changes in around infancy, early infancy and early childhood, with about 1/3 of cases being genetic, and actually more of the monogenic epilepsies being diagnosed in this age group. And the etiology remains unknown in quite a big percentage of 30 or so percentage of the cases. And this is a list of the most common genes that are identified as pathogenic in these early infancy, early childhood epilepsies. And some of them are benign, as the like the mental epilepsy, and some cases of intermediate severity. And then we move on to this age group, mostly school-age children. And then we have this concept of the benign seizure susceptibility syndrome that Professor Panagotopoulos, late Panagotopoulos, had coined. And this is a concept of immaturity of some networks that predisposes some children to have seizures that lower their seizure threshold. And this is genetically determined as well, but not monogenic in any way. And so we have families when a lot of members might have febrile seizures or these benign focal epilepsies. Febrile seizures are in between 3 months and 5 years of age. And these two syndromes, benign, self-limited, like we now call them, syndromes, with focal syndromes in epilepsy, Panagiotopoulos syndrome and Rolandic epilepsy, start later on, around school age or preschool years. And they are characterized by normal neurodevelopment and if we MRI these children, we have normal findings in both Panagiotopoulos syndrome and Rolandic epilepsy, which is characterized by centrotemporal spikes. The children might have seizures mostly associated with sleep, and especially in Panagiotopoulos syndrome, and they do have a very so even without having to take anti-epileptic medication, their epilepsies will remit when they mature with age. Then a little bit later on, we have the general epilepsies landscape, of course, in school age years. The mostly seen and recognized generalized epilepsy is that of childhood absence epilepsy. And later on, around puberty, we see this group of idiopathic generalized that have some features and some epilepsy types that are common in all three of them, and this is the juvenile myoclonic epilepsy. The main seizure type are myoclonic seizures, but we can also have absence seizures in this epilepsy and generalized tonic-clonic seizures, which is also the case for juvenile absence epilepsy. But here, the predominating epilepsy seizure type is absence seizures, and you can also have later on generalized tonic-clonic seizures. And then we have in even younger idiopathic generalized epilepsies who are mostly characterized with generalized tonic-clonic seizures. And these are a group of seizure disorders that are genetic. There are now, the preferred term is not idiopathic generalized, but genetic generalized epilepsies. But the underlying genetic background is multigenic, so it's not monogenic. But we can see them in families, and these correspond very well to treatment, but some might be lifelong. And then we have the epileptic encephalopathies landscape, which it starts from the first day of life, and it can move on to adulthood, but mostly you see that most encephalopathies are a feature of early childhood. And the main ones that are more common is West syndrome in infancy and Dravet syndrome in infancy, and then later on Lennox-Gastaut syndrome. And of course, the epilepsy aphasia spectrum with continuous spike and waves in sleep. So this is an overview of what we see in childhood epilepsies. Of course, most commonly, we see the benign cases. 70% of cases are self-limited or responding to therapy. How are we going to make the correct diagnosis? I think this that says everything in terms of how to approach a child who presents with seizures. We need to start off with seizure or is it a seizure mimic? And this is quite an important first step. If we take this step wrong, then this can be detrimental to the child. Then if we think we need to actually think if there is there's an acute provoked seizure, so something that directly caused the brain to be more excitable, or is it an unprovoked seizure? And then if we think that we have a recurrence of unprovoked seizures, then epilepsy, and we need to clarify which type of epilepsy we're facing. Is this a distinct epilepsy syndrome that we can identify, which is not always the case. It's mostly not the case to identify an epilepsy syndrome early on. And even from the beginning, as we said earlier, we need to think about etiology, especially if there are features of a treatable disorder, and never stop thinking about comorbidities and treat those as well. Now, we all know that diagnosis of epilepsy is based on the medical history. There is no test. There is no specific test to diagnose epilepsy, and we have to thinking on the history, because in most children, the initial physical examination and the initial investigations may be normal, and needs to think about all the differentials which are with syncope and a cerebrovascular incident, or migraine with aura, or psychogenic episode, or many sleep disorders that may look like some. We need to focus on taking the history from the eyewitnesses, and really think that inadequate history is the most common reason for misdiagnosis, and bear that in mind when we think that we don't have the time to ask all the questions. We need to go back, and if we're not sure if this seems like a seizure to us. Of course, we can demonstrate different seizure types, try to get the information from the parents, if that's a tonic seizure or if it's a clonic seizure. But of course, now we have the home videos, and when we have recurrent seizures, this is very, very helpful. What is the role of investigations? We all know that these are there to support the diagnosis. These are supplementary to our clinical suspicion. They can definitely be very helpful in making in classifying the seizure, the epilepsy type, and helping us to manage correctly, because there are different medications that we use for different seizure types, of course, and to recognize the underlying cause. And we know that we rely on the EEG as the initial investigation, and brain imaging, but of course laboratory tests are needed sometimes, a blood test and genetic testing. Now, I do provide here the guidelines as to the use of the EEG, but I think we've already know this. This is only to support the diagnosis, and normal EEG does not exclude epilepsy. We all know this. And of course, if from the history we think this is a syncope, maybe we shouldn't even do an EEG because this might complicate things. But it's very, very important to help determine the seizure type and classify epilepsy. Up to 50% of children might have an initial normal EEG, and they might have, even though they have epilepsy, which means that we need to have a second EEG, a sleep-deprived EEG, and even a sleep EEG. And then if we combined all these three, then the chances are more than 90% that we're going to have an abnormal test, which will help us in the classification. And there are specific cases that we might need a long-term video EEG or ambulatory EEG. When we have diagnostic difficulties or in pre-surgical. In terms of neuroimaging, we should aim for an MRI, which is the imaging investigation of choice. And we particularly need an MRI when we have early onset epilepsy, when we have any suggestion of focality in EEG, or when we have seizures that are not responding to treatment. And sometimes in acute situations, we might accept CT when we have no other choice, because it is helpful to exclude something acute, but it is not ideal. And we might need also laboratory tests, some blood tests to find an underlying etiology. The exclude some underlying metabolic disorder, or when we think of autoimmune epilepsies, and toxicology screen if drug misuse is suspected. And there is a very, very big role for genetic testing nowadays, especially in those difficult to treat or familial cases. So now we need to think, and we need to provide genetic testing for early epilepsies with and other neurodevelopmental comorbidities. We need to definitely do genetic testing for the diagnosis of a progressive myoclonic epilepsy, or some non-lesion with when we think of familial syndromes like autosomal dominant frontal lobe nocturnal epilepsy. And when we have resistant focal epilepsies and we do pre-surgical workup, or even in some focal malformations. But basically, when we have epileptic encephalopathies, this is where we need to target for the epilepsy. And just to remind ourselves, what is the goal of epilepsy management? Of course, the first goal is to treat seizures, even though we did say that epilepsy is more than seizures. Seizures are very important, and we need to try and lower the possibility of a second seizure or a third seizure in a child with a benign childhood epilepsy. Lower the amount of seizures a child has when he has a very, very difficult to treat epilepsy. And this we try to do with anti-seizure medications. You know that the last decades we have a lot new, the advance of a lot new anti-epileptic, anti-seizure medications. Some of them are based on previous medications. Some of them are new. But the question, and this slide is borrowed by Professor Ellen Cross, is anti-epileptic, anti-seizure medications improved our patients' lives. The answer here is not very straightforward, because what the response to these anti-seizure medications is, and if we have better control of seizures over time with all these new medications, I think we're not there yet with drugs, because approximately 1/3 of patients fail to achieve seizure control. This is the same as more we didn't have all these drugs available to use. And in these cases, when we have drug-resistant epilepsy, there are options. Go for dietary therapies as a ketogenic diet, or use neurostimulation devices. These are sometimes very helpful in reducing the seizure burden and improving the quality of life and improving the alertness of the children. And the goal, of course, is to find from epilepsy surgery and find them early on. And this is very important to bear in mind, because epilepsy surgery is maybe the only treatment that can be thought of as a cure for epilepsy. Because if we have an epileptogenic zone that we can remove, and then we can cure the patient and we can take him off medications, hopefully with a very good result. And they have shown over the years. So let's talk a little bit now about those challenges, the challenge of developmental epileptic encephalopathies and how this has actually given us some opportunities, and the application of precision medicine in epilepsy. So just to remind everyone about the developmental epileptic encephalopathies, this is a group of rare disorders, but even through the advances in genetics and genomics, 60 to 65% of these disorders do not have a molecular diagnosis, so we need to bear that in mind. And all the things that we are going to discuss are about relates to 1/3 of these encephalopathies. These are all related to an early age at seizure onset. EEGs are often aggressive, and the concept of the EEGs and electrical discharges contributing to the progressive psychomotor dysfunction is what has termed these epileptic encephalopathies, but also it is more and more recognized that the underlying etiology and the specific effect of the gene mutation is important as well. And sometimes the EEG or the seizures might be a little bit better controlled, and still we might have a progressive developmental delay. And this is why they are now called developmental and epileptic encephalopathies. The seizures in these epilepsies are commonly multiform and they are difficult to treat, and in most cases intractable. And they are associated with cognitive, behavioral, and neurological deficits that could be relentless and may even lead to early death or high percentage unexpected death in children. Review, just to show you, this is from a very good paper which was published in Lancet Neurology in 2016, an overview of the underlying etiology of most of the epileptic encephalopathies, and also what has given us the opportunity to try and find targeted treatments in these epilepsies. Here you can see a list of these targeted personalized treatments, and it goes from finding that carbamazepine is very effective in children who have the RRT2 mutation, respond to ketogenic diet, to also recognizing that some children who have specific mutations, as in SCN1A, and their loss of function, should avoid sodium channel. I think I lost you for a moment. Am I with you?
Yes, you're back. I guess you have to share your screen again, and then Dr. Dragoumi, can you hear me?
Oh, sorry. Yeah. Sorry. Are we back?
Yep, we are back. We can
Okay,
see your
sorry
screen.
for this. I would have never imagined this is the place where the internet would be unstable. Sorry. So I was talking about the precision medicine in genetic epilepsies, giving you an overview of what has been studied so far. So we know that for children who bear the SEN1 mutation that leads to the severe phenotype, we need to avoid sodium channel blockers, and we know that these can benefit from valproate and carbamazepine. This can be also correlated with seizures or not in some patients. And it is age dependent. We see that mostly in preschool and school years, and it remits in puberty. The fundamental feature of SS is the appearance or worsening of cognitive or problems associated with this increase in EEG epileptic activities in sleep. So this is where the concept of the discharges disrupting cognition comes from. This is an example of how the EEG might look like when we are awake, and then progressing on to this amplification of drowsiness and non-REM sleep, and these not go on to continue sleep. It was thought of when it was originally described that we need to have a percentage of over 85 of with duration of non-REM sleep duration covered with these discharges, but now the threshold, the spike and wave index threshold for the diagnosis of SS has been more flexible, and it can even be up to 50 or 70% of the non-REM sleep duration covered with if we have a clear enhancement of sleep discharges and if we have the clinical characteristics of cognitive deterioration. Also, another important issue is the topography of discharges. When we have mostly discharges in the temporal regions, we have receptic aphasia in the spectrum of Landau-Kleffner, and when we have either diffuse spike topography or frontal, mostly frontal distributed, we have global cognitive decline. In terms of etiology, why does this happen? Mostly we have the idiopathic SS that can be in some of the epilepsy aphasia spectrum epilepsies that we will see later on, where we have normal neurodevelopment before the onset of SS and normal neuroimaging. And the cognitive impairment happens with or without seizures period of the continuous spike and wave in sleep. And we can have the symptomatic SS, which is when we have underlying structural or genetic or metabolic etiologies. This is what I was referring to as the spectrum of idiopathic SS. We can have the development of these complication course of Rolantic epilepsy or childhood epilepsy with occipital spikes or benign epilepsy syndromes. And we can also have these epilepsy aphasias, Dow-Kleffner, or it can be due to some mutations like the green2A mutations that we mentioned earlier. And when we think about symptomatic or structural SS, we need to have in mind the unilateral polymicrogyrias that for this and congenital hemiparesis or shanded hydrocephalus. And we see here a case of unilateral polymicrogyria. And there's a video of one of our patients who had congenital hemiparesis and some focal seizures, but was doing normally well with his movement disability, but quite well-controlled seizures. And then he started in terms of speech and behavior, and we saw that in non-REM sleep he had almost continuous spike and waves, and these would disappear when he was awake. And eating this, and we'll see the way that we try to manage these cases, but he did not respond. So after a year, he was a year older, but he still had this pattern, this EEG pattern of increased spike and waves during sleep that would disappear on awakening, but he had a worsening. He actually had some atypical seizures that we see here that are very characteristic in this video. And we tried treating him with steroids, as we see, and carbamazepine and clobazam, but he did not respond. And we'll see that sometimes this and this pattern might go later on, just as the brain matures. So of activation of epileptic activity in non-REM sleep is something that we are well aware of in children who have these benign focal epilepsies, and we think that this is due to neural mechanisms that involve in the generation of normal sleep phenomena like sleep spindles. So this is also the concept of synaptic homeostasis hypothesis recently being described to try and make us understand why this increase in epileptic has the cognitive impact that it does. We know that sleep is very important for many functions in the brain. It's actually thought that it's the price we pay for synaptic plasticity, and I will explain this a little bit more. So we have our synapses, which are which overgrow due to our exposure, our everyday exposure to information, and all our everyday brain activities. And what actually sleep does is try to renormalize these synapses, because we need to downscale their size and make them more able to be effective for the next day, for our learning and for our activities. And this happens during and this is demonstrated here. So when we were awake, and we know that we build the number and the size of the synapses, but sleep, these have been much smaller, and this is important. This is actually mandatory for them to work properly the next day. And we can see here that as this happens, we have this can be captured with a lowering of the amplitude of the slow wave during slow wave sleep, and the slope becomes less steep. And this is what happens normally in controls, but with children with SS, we don't see this decline, this decrease. And this homeostatic recovery of the synapses. And this is correlated with the behavioral issues that we see when we have this pattern of SS. And actually, there have been functional studies that have shown that during spike and wave sleep, there is activation of certain networks and deactivation of the default mode network that is very, very crucial in neuropsychological processes. So this has been actually proved in fMRI studies as well. Typically there is a progression of symptoms in cases of SS, when at the first stage we might have rare seizures, mainly nocturnal, and some focal discharges that become more aggravated during sleep. And then there's the second stage where we have worsening of seizures and the complete EEG pattern and the neuropsychological regression. And then this moves on to the third stage after months or maybe years in some cases, when seizure and the pattern, the EEG pattern remains, and mostly the neuropsychological picture becomes better, not always. How do we try to treat SS in clinical practice? I think you all know that mostly we use benzodiazepines and steroids. There has been a survey that said that the first choice for most neurologists, adult neurologists, would be high-dose benzodiazepines, and the second choice would be actually valproate for adults. But there was a meta-analysis of treatments to see which are actually the most effective treatments for this condition, and the pooled analysis of a lot of retrospective studies has been that steroids and surgery, when we have structural cases, are the superior the treatments of superior efficacy. And this is a proposed therapeutic approach, which was published by Janssen's group in epileptic disorders. When we have a structural etiology, we go for surgery. And if we don't see improvement, then we use steroids or clobazam. But when we don't have a structural etiology, if there is just delay or arrest, we try benzodiazepines. If there is regression, we start with steroids. And of course, if there is no improvement, then we combine therapy. We can even resort to ketogenic therapy or IVIG. And because there is insecurity about which treatment is actually the preferred, there is this steroids versus clobazam survey, and the results are going to be published, I think, very soon. The prognosis of this condition, we need to think of it in terms of the seizures, the pattern, and the neuropsychological outcome. The seizures in this kind of epileptic encephalopathies tend to remit spontaneously, and the mean duration of the epilepsy seizure-wise is mostly 12 years. And this is independent of the etiological lesion. But the neuropsychological outcome can remain unchanged in almost 1/3 of patients, and this is mostly true with structural cases. And might determine this bad neuropsychological outcome might be a big elaboration of the pattern when we have age quite early on, when there is treatment lag. So when we do not recognize this condition and we not try to treat it, and there is this treatment lag that is sometimes the case, and when the response to treatment is not the one that we would hope for, as in our patient, and when we have a symptomatic or structural etiology. But this whole concept can make us think of the impact of the discharges on cognition, and this is a big topic that is actually one that has been studied in those benign self-limiting childhood is like Panagiotopoulou syndrome or Rolantic epilepsy. And a very good model for studying the impact of subclinical epileptiform discharges in cognitive functions is actually Rolantic epilepsy, which is a very common epilepsy. There have been many studies that have shown that there is a correlation between a high spike frequency during wakefulness and a high spike frequency in the first hour of sleep, and some academic problems, language delay, reading problems, lower scores in children. And this is actually accepted that there is this kind of impact, but we are not sure if there is a causal relationship or if this epileptiform activity is actually causing the educational impairment, or is this the cerebral maturational problem that underlines these. But it has been shown that even during the day, there is a critical role of the frequency of these spikes, and these interfere in the normal functioning of some language-brain networks. And in terms of the overall discussion about the effect of the EEG discharges and the impairment during these discharges, and if this is, there has been a review, an analysis of 32 studies that have been published in AIDS. And now we know that the epileptic discharges without seizures, the ones that we call subclinical, do have an additional independent effect on cognition, but this is mostly transient. And only in exceptional cases we can say that the epileptiform discharges are the dominant factor that explain a cognitive impairment. But it has actually been shown that such mild effects can accumulate over time. So when we have frequent epileptiform discharges that persist over years, and especially when this occurs during in the immature brain, the developing brain, these can then result in some effect on stable aspects of functions like the educational achievement. So there is a case for the transient cognitive subclinical interictal discharges, but this accounts for a smaller part than as we thought of previously. And the important thing is the effect of this being persistent over time in early on in the development. So that some people might ask, epileptiform discharges should be treated when we don't have seizures and we only have some cognitive problems. There's been a very review paper in the Epilepsia, and the authors ended up with providing a proposal that when we have asymptomatic subjects and we find interictal discharges, we should never think about treating. When we have some cognitive dysfunction with no seizures and florid epileptiform discharges, we should only treat when we are sure that there is a relation between the two and a correlation. And when we have ongoing seizures with cognitive dysfunction, then we certainly should treat the syndrome. And I'll stop here and give you guys time for comment. Thank you.
So we'll wait for like 4 or 5 minutes and then.
Can you guys hear me? I have a question if no one else does.
Yeah.
Okay. Hi, that was wonderful. I just have a question because you had a slide that showed all the primary generalized epilepsies with circles, and there was overlap. syndromes. And it reminded me of a thing I made 40 years ago about mitochondrial disease, the same kind of schematic I did with overlap syndromes. And my boss, Bud Rowland, went ballistic. He says, that's crazy. He called it a Venn diagram. And his view was you have to split these diseases in order to get good genetics. But even if they might be overlaps, you have to split them to do genetic studies. So the question I have, Penelope, is are the genetics of these disorders like absence and JME, and you said they were polygenetic and polygenic, I think you said, or rather than mono. Do we know anything more than that? Because I'm not sure I know very much about it. And maybe one of the problems is they're not split well enough, when you study them.
Yeah, thank you for the question. Actually, I think we are not very much more. We don't know much more things about this as we did earlier on. I think some genes have been suggested, and with the presence of some of these disorders in families, but I'm not sure that we have gained much more knowledge on this in terms of finding susceptibility genes that can predict the recurrence of epilepsies in later.
Okay. That's my understanding. I just wondered if there was more to it. But I just remembered my boss yelled at me when I drew a diagram like that, just so you know. He said, what are you doing? What is this? So it's kind of funny. So that's what I remembered getting yelled at.
Yeah, I'm sure we should start with better delineation of the syndrome, these kind of diagrams do not help. I think mostly what they aim to is to say that there is a spectrum with age of onset, and this was mostly in terms of saying that we can have the onset of seizures in even when we have a seizure starting at the age of 10. It could either be a late onset childhood absence epilepsy or a juvenile epilepsy syndrome. So
it's fine. I'm not criticizing it. In fact, there is phenotypic overlap, but I just remember I just wanted to bring that up, and sometimes it makes it harder to do gene finding.
That's actually very true, because sometimes we know of childhood absence epilepsy syndrome, which might then later on have features that can make the diagnosis of myoclonic epilepsy. So we also know that one syndrome can, after a few years, move on to another syndrome, which is another reason not to put them into these boxes and keep them there as diagnosis. But I'm very interested in the underlying etiology of these polygenic epilepsies, because we have now been focused on the developmental encephalopathies, and we know we have functional studies of the genes. We know their gain of function, loss of function, and we can target our treatment. But I don't think we have made a lot of advances in these polygenic genetic generalized epilepsies.
Thanks.
Thank you. I guess Dr. Giri has a question.
I have a comment and a question. I want to say, can you hear me?
Yes, but I can hear you perfectly.
Yeah, I just want to say thank you for a wonderful presentation. Was very, very educative, and excited about the ASO treatment that you commented on a devastating epilepsy syndrome like Dravet syndrome. So I'm excited about what's coming down the pipeline.
And the underlying thinking about the ASO treatment can actually be applied to other epilepsies when we have over excitability and over firing and increased firing, because these, if we lower the excitability with lowering the transcripts of this gene, this can have an effect on other epilepsies too. But of course, it remains to be seen how long this effect lasts and what kind of treatment that might.
Devraj,
Yes, Dr. Giri.
I wanted to say thank you to you for bringing international speakers. The world has become a smaller place.
Thank you so much. I guess that's it. There is no much. There's no questions. I don't see anything in the chat.
I think there's a raised hand.
That's Dr. Giri. She just.
Okay, that's fine.
Okay. So I guess that was really amazing. Like you went from basic to like advanced. Like I really liked it the way the presentation was, and I'm so glad that we have a PowerPoint so we can go through again in the future. And thank you so much for joining. And
thank you. It's been great being with you and you this talk. I hope it gave you some things to think about.
Thank you so much. You made it very easy, like for me to like even go and back and forth. It was like perfect. And
Okay.
my kind regards to Professor Zaferio.
Yeah, definitely, and have a lovely day and a lovely weekend.
Hopefully we can see you like in the next time in person.
I would really hope that. Bye-bye.
Thank you, Dr. Dragoumi. Thank you everyone for joining today.